So now to continue with what are the considerations. I have already told you that fully erupted maxillary molar is best. Second molar, if it has come, we can try. But for third molar is there, it should not be. Then mesially angulated maxillary first molars, discrepancy not exceeding 2 to 3 millimeter in the anterior region. So this is not important. Now coming on to recording molar position from the, we can draw vertical from the PTM and then we can measure a distance from distal surface of first molar to this PTM vertical, and there has to be age plus 3 mm of distance is considered normal. It is like that if we am attempting a molar distalization, it should not be that I should relieve the anterior crowding, rather the molars get stacked or molars get crowded. So we have to see how much space we have available in the distal position, distal to the molar when I'm moving the molar back. Then it could be achieved with the help of extraoral, intraoral appliances. It could be buccal, palatal, removal of fixed or interarch or intra-arch. These are the contraindications: retrognathic profile. Retrognathic profile, patients with TMJ disorders, skeletal class 2 malocclusion with excessive open bite, constricted maxillary arch, class 2, class 3 or class 1 molar relationship, or there are signs of posterior crowding. So this is a headgear which has a force bow, force element. You can see this is the inner bow which will go into the molar tube. This is the outer bow to which we will attach a safety release strap, that is a force delivering unit, and this could be attached to our this thing head cap, which could go in the nape of the neck or in the, as you can see, this is a high pull headgear which has a strap in the parietal as well as occipital region. This is a force element which is attached to the outer bow, and then we can apply a force for molar distalization. Okay, so these tubes, like if I'm using on the head strap on the nape of the neck, it will be for the cervical full headgear used for horizontal growers. The other one is for vertical growers. So basically, as I told you, it is for horizontal growers. So cervical full headgear was routinely used for molar distalization. Okay, and when for molar distalization, now this is the center of resistance of the molar at the trifurcation. If my forces are below this level, it will trip the crown. If my forces are above this level, it will tip the root distally. But if my forces are through this will move the molar bodily in the distal direction. So depending on the case requirement, whether crown is tipped, the root is tipped, or you want to take the full crown to both root and crown distally, we have to decide our biomechanics. This is the Wilson's biometric arch, which is inserted in the tube mesial to the molars, and this will help in molar distalization while using coil spring and intermaxillary hooks. Okay, then space regaining in mandibular arch is possible with the help of lip bumper. These lip bumpers, they are inserted into the molar tubes, and with the it has acrylic pad in the anterior region. As you can see in this diagram, there is an acrylic pad in the anterior region. You have a U-loop. Now the lower lip pressure gets transferred to this acrylic pad. From this, it is transferred to the wire. Because I have made this loop slightly wider, and what was the space, will tend to move the molar distally, or if it is tipped mesially, it will first upright it and then move it distally. Now these are the modified Nance holding arch. If there is, suppose this thing is there, one side, as you can see, we have given a Nance holding arch on one side, other it is attached to molar, and then buccally we have placed a coil spring for distalization of the molar. Okay, this is a pendulum appliance used for this thing. It has a two helix. Now this is inserted. We have made a Nance palatal button which is attached to premolar so that the anterior segment does not lose anchorage when I am doing a molar distalization. We first keep it straight like this, and then we'll insert into through the lingual sheath, and this will move the molars distally. This is a Pendex appliance, which besides having like a pendulum appliance, it has a springs made up of TMA for molar distalization. It also has an expansion screw. So we have combined two methods of molar distalization. We have combined two methods of gaining space in this appliance. This is a distal jet appliance, which is again a fixed lingual appliance used for molar distalization. Fixed piston appliance, you can see the figures. You can write the names at the undergraduate level. It's more than enough. This is the Echo appliance, which is a removable appliance attached to a headgear from the removable plate. Now coming on to last, that is extraction in orthodontics. Engel proposed a non-extraction philosophy where he said that all cases have to treat it without extraction of the teeth. Okay, but extraction of the teeth, but rather what happened that all the teeth relapsed. So they decided for undertaking, we decided to repeat the treatment for those patients with extraction of all premolars. So these extractions are needed whenever tooth material discrepancy is more than say 5 mm or more than that. We will do this thing so that the tooth material has to be sacrificed. Correction of sagittal interarch relationship like class 1, class 2, 3 malocclusion to relieve crowding. I told you earlier also maxillary and mandibular first premolar are the common this thing when space requirement is anterior segment more than 5 millimeter of this thing. Discrepancy is there. Second premolars are selected if I have to move the molar forward or if my discrepancy is say lesser. So we need to move the molars forward both upper and lower arch. Then also we can say all five, or if it is a class 2 malocclusion, lot of overjet, we can remove upper premolars and we can remove lower fives for moving the molars forward. The mandibular incisors, they are done when there is a Bolton discrepancy with mandibular arch. Normally, maxillary arch is normal, lower arch has certain crowding, the tooth is one quietly displaced out of the arch. So this, in these conditions, we can undergo mandibular incisor extraction. Now, arch expansion, this is last method of gaining space, and this we can achieve with the help of slow maxillary expansion, rapid maxillary expansion, or passive expansion as with the myofunctional appliances. Indications, correction of unilateral cross bites, minimal crowding, V-shaped arches, and when I want to bring the mandible forward, if maxillary arch is constricted, I have to add expansion to it. So this is expansion when a patient is going, say this is a mid-palatine suture which is not ossified. So this will cause an expansion in adults. It is not possible to expand the future suture. So in that case, if I'm attempting expansion, it will be mostly dental in origin, or if I want skeletal expansion, I should split the mid-palatine suture surgically and then I should apply give some type of screw for the expansion. So slow expansion achieved with quad helix, W spring, RMA with the help of higher X, Haas. This can separate the maxilla in deciduous and mixed dentition. Rapid is given before the fusion of the suture. And in this, you can say slow expansion, you can remember it 1 mm per week, rapid expansion 1 mm per day. And this will bring more of skeletal changes only when the child is small. Otherwise, it will bring about dentoalveolar expansion. Rapid expansion gives skeletal changes. It is a slow, takes more time. Rapid expansion is achieved faster. You can say this is a coffin spring which we can activate and gain expansion. This is a quad helix which can be fixed onto the molars to gain expansion. Then in rapid maxillary expansion, uh, uh, rapid maxillary expansion can be done with the help of Hyrex. It could be bonded or bondable type of appliances which can do. And this is generally done at the age of 13 to 15 years when suture is not ossified. And once the RME expansion is achieved, you will see the midline diastema that time. And once your desired expansion is achieved, you can block the sutures with the help of acrylic. This will act like a retainer. So you can see these are the appliances, one which is attached with the bend, attached with the crowns, or you